Good evening, everyone. It's indeed a pleasure to meet you all today at this ISHK FNB teaching program. At the outset, I would like to thank Dr. Dhanashekhar Raja for giving me this opportunity to talk on this very important subject of Varus Knee. I'll begin by sharing my screen. We all know that varus is a very important component of all knee replacement. Majority of the knees that we do today have the varus deformity, and it is important to understand varus in a bit of depth, classify them properly, and use an algorithmic approach to its management. My name is Vaibhav Bagaria. I work at the Sir H.N. Reliance Foundation Hospital in Mumbai. And as I said, today we'll start with the anatomy, look at the classification, look at the soft tissue and the bony management, and on the way, learn certain tips and tricks of managing these varus knee. These are all the structures that are responsible for soft tissue contracture at the varus site. So the most important structures here are the deep medial collateral ligament and the superficial medial collateral ligament. Of course, apart from that, semimembranosus, posterior oblique ligament, pes, and capsule along with MPFL are the other structure that contract or alter during a varus knee. As I said, the two most important of these are the DMCL and SMCL. So you'll see that the DMCL is quite close to the joint. It says between this, and it's a very short structure here that forms DMCL. Whereas the SMCL, which is the superficial medial collateral ligament, is an elongated structure. It starts nearly 3 centimeter proximal to the joint line and goes up to the 7 centimeter below the tibial plateau. It is important to understand this anatomy because this is a sacrosanct structure. This is a structure that you release very carefully, and certainly you do not want to erase its insertion or origin, because if you do that, you will end up either requiring some kind of constraint or a hinge when you are doing a knee replacement. It's important to know the shape. You see this shape here shown on the figure there and here as well. It has got a very peculiar shape. So the SMCL and DMCL are the two important structures. And why I'm talking about this, when we go on release, we do what's called as a top to down approach. So most of the initial deformities are at the top level, which is because of the osteophyte, followed by the DMCL, followed by posteriorly semimembranosus, anteriorly the pes, and at the very bottom is the SMCL. So for majority of your knees, 70 to 90% of varus knee, you only need to remove the osteophyte, DMCL, and capsule. In certain patients who have got a more severe degree of deformity, you go to semimembranosus, and the SMCL you should rarely touch. Similarly, you can see this as a clock concept. So when you begin releasing a varus knee, you start by releasing capsule, you go to DMCL, maybe some amount of SMCL. More posteriorly is the semimembranosus, posterior oblique ligament, PCL, and popliteus. So indeed, when you look at this, most of our release will stop in the first segment here, from here to here. So if you look at this knee, which is a right knee, so if it is 6 o'clock here and 12 o'clock here, you start from 6 o'clock to 9 o'clock, wherein you have removed the capsule and reached up to DMCL, and most of the knees will require that amount of release. You need not go beyond 3 o'clock ever, because if you're doing that, that means you have not chosen the uni with the right indication. If the deformity is more severe, then you go up to what is called as the semimembranosus and posterior oblique ligament. More severe deformity requires PCL to be tackled with, and even certain deformities in which you find subluxation and a big degree of varus will require popliteus to be tackled or elongated. Similarly, you come from top to down. So you're going from this to this and top to down as the degree of deformity increases. Very important to understand, because once you understand that, you will only release what is really required. We all know the varus is defined when the Mackay line, which is the load-bearing axis that passes from the center of the femoral head to the center of talus, is medial to the center of the knee joint. Classification was originally given by Thinpont and Parvizi, and it was a very intuitive classification because it classified it into whether it is intraarticular diphyseal deformity, metaphyseal deformity, or purely diphyseal deformities. And again, they subclassified it into reducible and fixed. So this was a very intuitive classification where you could say, okay, is the deformity here, here, or down there? If it is here, whether it is fixed or correctable, whether it is here, whether the joint line obliquity is maintained or distorted, and if it is there, where it is, whether it is femur, tibia, or both. Now, the reason why I've been asked to classify or to take this lecture is because we published a modification of this, which is now called as Bagaria, Thien, Pond, and Parvizi classification, where we looked at varus not only in the terms of the degree of deformity, which is the stage, but also the type of varus that it is and the location. So three important things that I think when we look at the varus deformity is where does it lie, which is the location, how big it is, which is the degree, and how is it pathologically, which we call as grade. So you look, we classified this into three stages. Stage 1 is an alignment, varus alignment up to 10 degree. 2 is between 10 to 20 degree. And 3 is more than 20 degrees. And then we classified it according to 10 things that we felt are very sacrosanct in varus. The first grade has 3 common features. We know that they have femoral osteophyte, joint space narrowing, and tibial osteophyte. So the most simple varus will have this thing. And as I said, just removing the osteophyte will suffice here. As we move into a higher grade of varus, we'll find that the femoral condyle starts to get flattening. There is some tibial defect, and some of them have metaphyseal bumps. And the most severe type of varus is the one that have subluxation, some stress fracture and remodeling at the tibia, and more severe degree will also have a fibular remodeling. And we'll see a few examples here when we look at this. So you look here, the first one is grade A, simple femoral osteophyte, joint space narrowing, and tibial narrowing. Grade B, you have the femoral flattening, tibial defect, and a metaphyseal B. And in grade 3, you can clearly see that there is a greater degree of subluxation. The tibial plateau has remodeled, and you can even see a fibular remodeling. So we know that not only just the stage, which is the degree, but also the depth of the deformity or the severity of the disease in form of these features are important. And that is why we call that it has to be a 3-pronged approach: stage, grade, and the third thing, as I said, was the location. Now, truly, if you ask me, what is a knee joint? I think knee joint is different for different people. If you ask a deformity correction surgeon, it will be a joint line. If you ask an arthroscopist, he'll say anything between the capsule is a knee joint. But I think for us knee replacement surgeons, the area between the ligaments is what is joint, because between that you can play whatever you want to. And when you're talking about varus deformity, I think it is the area between the two SMCL insertion that is what constitutes joint for us. So any deformity which is beyond SMCL is extraarticular or extraligamentous, and that is, they have to be treated separately. So as a part of this study, we did to see 3 things. Where is the deformity? Either femur, tibia, or at the joint, and how many of them were extraarticular. So as I said, we took this thing as 3 centimeter proximal to the joint line and 7 centimeter on the tibial side. And anything out of this was called as extraligamentous or extraarticular. So you'll see that here we have drawn a epiphyseal axis and a tibial axis. And since it is lying outside the 3 to 7 centimeter margin that we have chosen, this is more likely to be extraligamentous. And indeed, in our studies, we found, we did it for 100 cases, that the 14 cases had an extraarticular deformity, which is more than 7 centimeter from the joint, which can also be called as either a constitutional varus or an extraligamentous deformity in around 14%, which is around 1 in 7 case will have a deformity which is outside the joint. Within the joint, most of them will have combined deformities, with predominantly people having deformities at tibia, which is 53%. 27 will have it at joint, and the 6 will have it at femur. So it is very important to understand where the deformity is to be able to do that. And I'll go back to this slide where I've said that as when we begin, we must calculate LDFA and MPTA to understand where it is happening, and also the joint line congruence angle. So these are 3 simple lines. I think when we start doing knee replacement, we must calculate for each case. So this is a simple intraarticular deformity. We all know that. This is a sort of metaphyseal deformity. On the left side, you will see a reversal of slope, which is because of post-H2O status. So again, all are varus, but all different varus. Then you have got something that you need to look in the posteromedial wear, which is a PAGODA deformity. So that's the importance of doing a lateral X-ray when you are looking at the varus deformity. And finally, as I said, it is important to look at the femur and the distal and the tibia below the joint, and it could be extraarticular deformity. So in nutshell, not all the varus deformity are the same. You see here, it's a very different deformity. Here you'll see that there is a metaphyseal bump. This is like a grade B. And of course, then we have grade C, which is completely subluxated. So you saw the entire spectrum of the deformity. And usually higher stage will correspond to higher grade, but not necessarily always. There will be certain deformity which are low stage. You'll find only 5 to 7 degree varus, but they are still dangerous because they are higher grade with subluxation and tibial and fibular remodeling. So be aware. So once again, when you look at the deformity, you have to think in three terms. What is the stage, which is the degree of deformity? What is the grade, meaning what is the type of deformity? And number three, where is it located? Femur, tibia, joint, combined or extraarticular. So once you do that, you have understood and you will be able to balance your knee better and use appropriate things to do this. As I said, think in terms of anatomy and classify, decide in terms of soft tissue and bony deformity, and execute with special technique. So when we look at this, we see what kind of deformities. As I said, 1 in 7 will have extraarticular. So these are the ones which will benefit most with the use of technology, either a pinless navigation, PSI, robotic, or extramedullary jigs. If it is in and around, then if it is mild, as I said, your release will be limited and you can manage with cuts. If it is moderate, you have to do slightly more gap balancing with this. And then severe deformity, you can have your releases going along the whole clock concept and inverted pyramid approach. Basic tenet for any varus deformity is to plan well, classify, do medial release, remove all the osteophyte, remove the metaphyseal bump if it exists, look at the quadrant of deformity, manage the bone, and always remember to avoid over-release. So when I begin, we start from, if there's a severe knee, we start with a limited medial release, elevate the DMCL, remove the meniscal attachment. Many people will just end at that level. Once you have done that, ensure that all the osteophytes are removed on tibial and femoral side. Then if need be, we can do a semimembranosus release. Then if need be, a subperiosteal PES release or SMCL release. But remember, it has to be very carefully done without doing too much. In large knees, then we go to the bone where we can use a shift and resect technique. In smaller knees, predominantly tight medial structure, instead of shift and resect, because you don't have a large bone, you use pie crusting. And sometime if everything fails, then you have to consider an epicondylar slide osteotomy as the last resort. So if you use this, majority of your 90-95% will stop at the third level of third tier of it. Then there will be, depending on how your deformity is, you will keep changing the whole thing. Medial release, the intent has to be a sequential release so that the medial structure reach a length equal to the lateral structure. Always create a sleeve. And that is why a medial parapedal approach is preferred, because you can create a very nice sleeve around it. The periosteal elevator, I think that's very important where it is passed. It is passed deep to the superficial MCL so as not to damage the MCL. It should start 3 to 4 centimeters below the joint line so that the flare, the tibial diaphyseal, the metaphyseal flare starts. So this is the typical portion where you should insert your periosteum. And then once it is done, you can insert a bent Homan to create the sleeve. So you see, we are starting at almost 6 o'clock. We are removing the DMCL, and then we are inserting our periosteum at this level here. Not here, not here, but here. A curved periosteum and then sleeve. As I told you earlier, it starts with DMCL, posterior capsule, superficial MCL, POL, semimembranous, PES, and finally popliteus. Do not, even if you have to release, your subperiosteal dissection is very crucial so that everything heals back once your balance is restored and the knee is back into action. See where the semimembranosus is. Semimembranosus lies right here, and you can see how it is released. You can use a cautery or you can use a knife to cut that structure to release it. Not required in all cases, but still in severe varus fixed deformity, it is a useful tool. Posterior oblique ligament lies just besides the semimembranosus there, and you can see that's being released. And of course, as I said, osteophyte removal is usually the second step after you have cut the DMCL and the capsule. Do not forget the femoral osteophyte. They tighten extension gap most often, and they need to be released. Okay. For severe deformities, as I said, if their deformity is severe, you may need to go up to the cruciate. And it is better to use PS type of knee. You can either cut the tibia more or release the PCL. So I think the debate between the CR and PS is now obsolete because you are doing a patient-specific implantation. In certain patients, it is important to sacrifice PCL so as to achieve correction without taking more deep tibial cut. Remember that a non-functioning PCL with CR knee will prevent rollback functioning and cause anterior opening and losing. So you have to be very careful when you choose to do CR knees. Always do it in indicated cases. PCL, as I said, you can either release through bony attachment, can be released using an osteotome, or it could be an intrasubstance release to improve the medial structures. So paradoxically, although it is at center, it is still, and that same goes with popliteus also. So once that's done, the posterior release can be done. As I said, the structure starts from 6 o'clock and goes all the way to the 12 o'clock. And sometimes you have to do this. And sometimes even the medial head of gastrocnemius is required to be released to correct the varus deformities. Once that's done, check the gaps. If it is still not happening, then you do what is called a shift and resect. You have to undersize the trial tibial component and remove the medial excess bone with either a saw or osteotome. So you see here, we have marked the thing with a pen, and then you remove it. So the extra bone along which the medial structures are tenting will get released. We are using a saw here to cut the bone here. And you see again a very subluxated deformity knee in which you can do this, and that is how it balances out. Pie crusting, if the knee is small, then you do not do shift and reset because there's a limit to what small size tibia you can use. So use a 16G needle. Remember, if it is tight in flexion, you have to remove the anterior, you have to pie crust the anterior thing. And if it is posterior, if it is tight in extension, it is the posterior fiber contributing to it. 5 pricks at one go, giving a valgus stress. This is the technique of doing it. Give a valgus stress, use 5 pie crust needle pokes. That's how we are doing it. A good table, but not always accurate. Largely, the superficial MCL is anterior fiber are responsible for flexion gap, as we discussed. And similarly, the posterior fiber are responsible for extension gap. Deep MCL is for both. And all other structures influence, which are posteriorly, are responsible for extension gap. That includes POL, semimembranosus, PES, posteromedial capsule, and medial head of the gastrocnemius. People often ask me about the residual laxity. So lateral laxity post-balancing can be an issue. But remember, some laxity is acceptable because IT band is a dynamic stabilizer. In fact, people who have slight residual laxity seem to function or feel a better functioning knee. If need be, if the laxity is too much, then that means that the knee is still unbalanced. You need to do a medial release to increase and use a thicker poly. Rarely you use, I have never used, but people say that an LCL advancement is an alternative if there is too much of residual laxity. I can't finish this talk without talking about robotics, because robotic has become a very important tool nowadays to balance the knees. And you'll see here, I'm balancing the knee. I'm sure there will be other lectures talking about this, but this is just one illustration. We'll see the tightness here. The orange is the medial tightness. So once you have done that with robotic, you can give a varus valgus stress to see how the knee is tight in flexion and in the varus and valgus. So although I'm giving a valgus stress still, because it's a traction or distraction force, the lateral side is opening up. And this is now when I'm giving a varus stress, the lateral side increases further. So robotics allows us to see how the structures are doing dynamically. So all the purple thing is the gap. So you'll see the flexion and extension both have lateral gaps, which are significantly higher, and the medial side, which is the tight. And with the few juggling of the components, I'll be able to achieve a lot of things. So I've converted the poly to 11 here. You'll see immediately the extension has started getting to be balanced. Then I'm changing the depth of the tibial cuts. Then I'll change the femoral size. Let me see what I'm doing. I'm changing the femoral rotation now. Then you'll see that I'm notching here. Then I will probably change my femur size to 4. So you see how we are balancing it using robotics. You see, the moment I do that, I can see that my lateral side is tightened. I've changed the size. And you'll see in the end, so in the robotics, the key is to balance the normal side first. You balance it, and whatever residual tightness remains, you correct it with the releases. So you'll see what I'll do is, at the end of this, I'll ensure that my lateral side in both flexion and extension is nearly balanced. And then whatever laxity is remaining here, tightness is remaining, which is medial tightness of 3.1 and lateral tightness of 5.3, I will try to do it with the releases that I just mentioned to all of you. You can see here. So I have balanced lateral side in flexion to get 0, 0. In extension, slight laxity I'm accepting. And then whatever is remaining, I will now start my releases. So robotics, so you see how much mismatch was there when I started the robotic screen. And now it has reached to a level where my releases would suffice. So I think technology has got a big role in helping us prevent the varus deformity. Take-home message from this lecture is that always assess and plan. When you're doing a release, create a medial sleeve. Do complete osteophyctomy. Sequential release is the key. When you can't do that, use shift and resect or pie crust if the knee is small. Stage and grade are both important. As I said, stage 1 and grade 1 is the easiest one to balance. Stage 1 and grade C is the difficult one. So all type Cs, although they are either stage A, stage 1, 2, or 3, are more difficult, and ones that should be thought of where you should use PS implant, stem extension, or use technology. And these are also the ones. So if you've got a stage 3C, there is some scope of leaving constitutional varus. That means your degree of deformity is more than 20 degree, and the grade of deformity is also very severe, and it has got an extra-articular deformity. Then I think there is a case for leaving constitutional varus. So this is, in short, the algorithm, and I think this is a key thing. If you do this, your varus deformity becomes very simple. So I thank you all for your attention and welcome you all to Mumbai. And there's a reason why I invite you to Mumbai is because we are conducting the first Technique and Technology in Joint Replacement course, TTGR 2023, on 31st March and 1st April. It will be primarily focused on technology like robotics and other important things that are changing in arthroplasty. There will be a hands-on workshop on all major robotic systems. You can visit the website www.ttgr2023.com for more details and registration. Thank you once again for your patient hearing, and I look forward to meeting you all at the TTGR. Thank you. So thank you, Dhanashekhar Raja, and any questions, I would welcome you at this stage. Thank you.